we'll go ahead and just jump in. Donna, if you'll just watch and anyone who needs to come in, that would be great.
You betcha.
And Maya, I'm going to hand it off to you in a second. But I think everyone who's on now knows that the reason for this is just a way to increase collaboration amongst a lot of us that are in different practice settings, and how can we find topics that make sense and are interesting to people both in Monterey County and Santa Cruz County and San Benito County. And so we came up as a brainstorm with a lot of you, especially last year at the CMA, was a speaker series. And then with kind of boiling it down with Donna and Tira, we thought we'd do a 60 to 90 minute every other month. That seemed like enough that we could support, not too big, and then shoot for 30 people or so, which hopefully we'll get close to that tonight. And the first two, so we'll do every other month for 60, probably it's just about an hour tonight, a little over. And then January, March, May, so on. So 6 topics a year. And the first two, I think, will both be around access, and the next part will be around what Monterey County is doing, and try to bring in that perspective a little more. So that's what we'll be leaning on folks to help us with. And then later in the year, since we're close prime, I thought maybe a topic around MAT and Suboxone therapy. Reb Close is an excellent speaker. She could hopefully speak with us, Monterey perspective in the summer. So with that, again, this purpose of this is to learn from each other. We'll do 10 minutes each with the speakers, and then a Q&A 10 minutes after each. So Maya will go for 10 minutes. I'll moderate 10 minutes so everyone open to questions for her. And I'll do the same next with Dan, and then we'll end out with Casey. So if it's okay, and I hope you can have your slides up, Maya, if you want to just self-introduce and then go for it, and I'll be quiet for 10 minutes.
I'll just do my intro and then I'll put up my slides. So, good evening, everybody. It's nice to see some familiar names and faces, and hello to everybody that I haven't met yet. My name is Bui-Duy. I'm medical director at the Alliance. A little bit about my background. I trained in internal medicine at UCSF in the primary care track. So primary care is my passion place. So I'm very happy to be here and share that perspective. I graduated in 2013, stayed in San Francisco stayed at UCSF for a couple more years after that, and then my family moved down to Santa Cruz. So I joined Salud para la Gente in 20. I've been working remote a little bit in 2017, but I moved down here in 2018 to serve as their Director of Health Information and Population Health. I stayed on with them for 7 years, and then just last year transitioned over to the Alliance. So I'm celebrating my 1 year anniversary in a very different role now, but still on the big advocacy train for primary care. So yeah, that's just a little bit about me. And so I'll go ahead and share my slides. And put this here. I just have a couple of slides mostly to help keep me on track with my thoughts. But when Clay asked me to speak, and kind of brought up this idea of patient access and challenges, I was like, oh my gosh. I mean, there are a million ways that this could go, and I think fundamentally this seesaw or imbalance is kind of really the crux of it for me. I know there are a lot of folks on here who are working on the primary care supply side. So I won't speak too much about it. When I had talked with Clay, he was really interested in sort of me sharing my experience when I was at Salud, particularly around patient access as regards to hospital follow-up visits, because as we all know, it's just very different. It's very difficult to get primary care appointments. You can see there's a lot of demand on primary care. And hospital follow-ups are really, really important, right? So how can we facilitate that from our end on the clinic side? So I'm sure many of you are familiar with Salud. I just thought I would kind of share some basic stats. The Salud is FQHC located in Watsonville, so we are in South Santa Cruz County, but we care for predominantly the ag community, both in South Santa Cruz County as well as North Monterey County. Predominantly low-income Latino patients, majority of whom are Spanish speaking, but also some indigenous languages. And we have full spectrum primary care, so pediatrics, family medicine, women's health, prenatal care. As a FQHC, we also have optometry and dental services, as well as BH case management and even some specialty services. So we share uh, our patients, we share clinic space, and we share staff even with Watsonville Community Hospital. So we have a really close partnership with the hospital. Um, I just put this picture up to show, essentially what you're looking at is like the front office of the front doors of 65 Nielsen, one of our clinics that's on the same campus as the hospital. Something we don't share with the hospital is our EHR. So uh, both the hospital and Salud use EHRs that many people have never heard of. On the clinic side, we use something called Greenway Indragy. At the hospital, I believe it's MedHost. And yeah, clinical communication can be a challenge. So back in 2024, I had started a project really trying to work on improving more real-time clinical communication, especially around discharge, where it's really that important transitions of care period. And essentially, we went through a couple of iterations of solutions. The hospital at the time was trying secure messaging, internal messaging. We tried to jump on the bandwagon unsuccessfully, but what we ended up landing on was a very low-tech solution of the phone. Essentially, we created a dedicated backline number to our call center. And I think the real secret sauce is not that we created a backline to our call center, it's that in our call center, we have a triage nurse. So the triage nurse, their role is really to help the call center, who are non-clinical staff, field questions from patients who are calling in. The call center triage nurse will, hop on the phone after the call center staff kind of passes it over to them just to triage, like, what are your symptoms? Is this something that you need to be going to the ER right now? Or is this something where they think that, you need an appointment, but you need it kind of more urgently? You can't just wait, a week. We got to get you in, quicker than that. And so the call center has really close relationships with our providers. Um, we also are very fortunate at Salud to have a group of same day providers. And I think this is also kind of the second piece of our success for this is to be able to have a group of providers who do just same day visits. So they don't carry a primary care panel. This is kind of actually by their choice. We have a group of providers who are very interested in doing same day care. And so it could be, sick visits. It could be ER follow-ups, hospital follow-ups. Ideally, in the call center, they try to schedule appointments with the PCP or somebody on the PCP's team. But if that's not possible, this group of same-day providers is available as a resource. So essentially kind of an in-house urgent care. And so that call center triage nurse is a really powerful resource to be able to, clinically sort of assess patients over the phone and determine what level of care is needed, and then have that relationship to work with providers in the back office or to work with the same day providers to, overbook if needed or shuffle around, sort of Tetris the schedule so that we can get patients in a timely fashion. And so, by creating this backline number, really it's the backline number to a clinical person when oftentimes it can be pretty challenging to get a hold of a PCP who's in clinic seeing patients at that moment. So in April of last year, the backline number was created at Salud in the call center. And at first, we just shared it with the lab because actually the lab was having a hard time when they would get urgent or critical labs that were ordered by a Salud provider. They were kind of having a hard time connecting back to the ordering provider. And so this was kind of an easy way to just sort of test this idea of a backline number. We got some really good success. And so in September, we expanded it to sharing the backline number with the ER folks. And I think from that perspective, we were really hoping that, for the ER, especially if you were wanting to avoid admission, if it was sort of like a borderline patient and you thought as an ED doc, like, well, if I could just guarantee that they would be seen by a PCP tomorrow and check on these one, two, three things, they wouldn't really need admission. They could get away with just super close PCP follow-up. But I think in the past, you would call the call center and, it was non-clinical staff. So there's a lot of primary care demand. Maybe the next appointment is like a couple of weeks, if you're being really optimistic, frankly. But because, the ED now has that kind of backline access to the nurse, the triage nurse really understands the importance of timely follow-up. And so if the ED doc is saying, I need an appointment like tomorrow, then the triage nurse has that authority and capability to look at schedules, find an open slot, or at least, be able to contact a provider if there is no open slot about how can we rejigger your schedule to make there a slot for, what the patient needs. I was pretty successful, and then we just a couple months later essentially opened it up to the hospital medicine team. I don't know if Clay wants to share his impressions, but some of the data. This was when I was still more in touch with the Salud team, but in the initial pilot in April, for a couple of months, that was the response time to the call center triage nurse, 13 seconds on average, compared to if you tried to just call the, general call center line, you could be on hold for up to 3 minutes. So, it might not seem like a lot, but, as you all know, when you are busy seeing patients, like you don't really have 3 minutes to just stay on hold and not really know if it's really going to be 3 minutes or not. And so I think really, folks expressed a lot of appreciation for just really the rapid turnaround time for calls. Um, so that is essentially kind of one solution that we had at Salud to just addressing uh, patient access and with the sort of the lens for hospital follow-ups. I did just want to share, now that I'm at the Alliance on the health plan side, one thing that we've been doing a little bit more on sort of the primary care supply side is really trying to support provider recruitment. This has been one of our most popular grants over the past decade, and so we continue to host this. Our budget, unfortunately, is shrinking as our membership is also shrinking. But this is really something that we are committed to. We really have heard a lot of feedback from all sorts of providers, hospitals, clinics. We have CHW recruitment program as well. So all types of providers as well. How popular this grant program is. So I just wanted to share that as well. And I will stop here.
That was perfect. Thank you. You've been an amazing partner over the year. I've loved talking to you. We, as we talk every month about half an hour or so, and it's really nice to kind of connect and understand what each other's doing. And I was so excited to share your innovations. And what I loved about what you just showed is a clinical communication. You have to go back to the basics sometimes. And what you did with that phone line, it was in the seesaw, it was perfect, and it's really helpful. And I know there's a couple of folks from Watch of the Hospital on now and from administration, and this is the stuff we have to do when we have HIE problems. As we all know, we're having issues with the SCIO, and now we're changing over. So going back to the basics and communicate with each other like that, and kind of breaking down those barriers is what this has done. And I'm very, very happy that you've shared this with us. And I will just open it up. We have about 9 minutes for some Q&A. I'd love to get some discussion going and learn from each other. So anyone have some questions about the logistics or the data, which was nice to see both.
Can I jump in with the question?
Sure.
I'm
Yeah, raise
sorry.
your
Yeah,
hand or
yeah.
jump right in.
Yeah, great presentation. And I'm John with Clínica de Salud, just across the Pajaro River with the Pajaro Clinic and in Monterey County. So yeah, great. Now I just have a question about the the triage nurse. Now, is that there's a dedicated RN then to handle all the incoming calls for patients who want same day appointments or have acute illnesses?
Yes. So the call center nurse is stationed in our call center. Um, they don't automatically get tapped. If we call them the patient access representative, so that's the call center staff or the PAR. So if the PAR is able to find a same day appointment and the patient, wants a same day appointment, they don't have to, necessarily tap the nurse in to help triage that because the patient's like already going to be scheduled to be seen. It's more like, if the patient's like, if they don't necessarily, if they're saying like, I want an appointment right now and here are my symptoms and then the par can't really find an appointment and they're like, oh, I don't know what to do. Is it okay to schedule in a week? Is it okay to, the PCP can't even see them for like a month. We have somebody else who can see them in a week. Is a week too long? Like those kinds of questions, they don't have the training to sort of answer that. So that's when they'll do like essentially a warm handoff to the call center triage nurse, who's like physically there as well. And so then the triage nurse kind of takes that call and talks to the patient, sort of gets more of history and can sort of say like, you know what, based on what you're telling me, actually you need to like go to the ER right now, or what, there are no appointments today, but if try these supportive measures at home, and we'll get you in with the same day provider for tomorrow at this time. So the patient will kind of leave with a appointment date and time, or at least some kind of sort of instructions.
Okay, because that's
That's great.
similar to what the CCA has that
Yeah.
process for.
Yeah, yeah. So, yes, thank you for pointing that out. I'm so glad. It's very funny because on the Alliance side, a lot of the staff are like, nobody ever talks about the nurse advice line, and I was like, I don't know what you're talking about. We use it all the time, but it is essentially it is a version of the nurse advice line. Of course, you can imagine that the advantages are that so the nurse advice line is sort of a contracted partner that we work with. I think that the advantage of having it in-house, obviously it's more expensive because it's, they don't have reimbursable visits. These are not like
Yeah.
visits, but they have access to the EMR, right? So the triage nurse is able to like go through the patient's chart, see who the PCP is, see when the last visit was, see what happened at the last visit, kind of use all that clinical judgment. It's quite a challenging role, really. But the advantage of having that person being in-house and then, of course, having those relationships with the back office staff and the providers, right? If I know that Iriana, who's our call center triage manager, if I know Iriana is calling me, I'm going to answer that because clearly something is up to the point where the triage nurse is calling me, like something's up with my patients. I'm gonna interrupt my clinic day to answer, like be like, what can I do to help you? It's gonna be 2 seconds. What do you need?
Okay,
So I think that relationship is really important.
that's really helpful, and I don't want to monopolize the whole discussion. I just have one quick follow-up question. For protocols, is there like standardized triage protocols? Are they
Yes.
published? What do you specifically use?
Good
Oh,
question.
that is a good question. We do. I'm pretty sure I have seen. Oh wow, now I'm like wishing I was like paying more attention during those compliance meetings. But I know that they have a manual that they reference. But then I believe they also have some internal workflows that are published as well. I believe part of that might be more for the non-clinical staff to help consistently guide them, like when do you need to tap in a nurse, like if a patient's mentioning like chest pain or like
Yeah.
certain symptoms, it just that does automatically go to the nurse. I believe the nurses have some textbook that they or some manual that they reference, and if you would like, I'm happy to
Yeah,
uh,
that would be great if you could, email me that, John has my contact. And I just really last comment is our Kaiser colleagues here. I think Kaiser has a very robust nurse triage program too, right? And it'll be interesting to see what protocols they have. It's something that, yeah, if it's proprietary, that's one thing, but if it's based on published guidelines, that'll be really helpful to know. So anyway, thank you very much. I'll sign off.
Thanks, John. It would be interesting to cross-reference those, Mai. So once I see what you have, and I see Jack Watson's on, maybe we could have some crosswalk on that. That's a great topic. All right, we have a few more minutes for questions. You answered the question I was going to ask you, which is what do you feel is the biggest challenge with patient access to care? Unless you want to elaborate that anymore. Do you have one that reaches to the very top? Usually it's getting an appointment, getting the care that you need, but go ahead if you want to elaborate on that a little bit.
Yeah, I would echo that. I feel like I don't know, maybe this is like t touting our own horn too much, but like once you're established, I'm sure any clinic feels this way. Like once a patient is established, it's just so much easier to access all the services, right? But I think one of the real problems is like we feel a lot of demand from our community for new patient access, and we just don't have the clinicians to support that, right? And I think that's where kind of the primary care, the medical student program, Prime Central Coast, residencies at Dominican, like all that really comes into play because we just don't. And then sort of like, recruitment at the sort of provider physician level, but we just don't. We're very protective of the size of our PCPs panels because our patients are complex, but also we don't want to burn out PCPs. They're already a limited supply. Like we don't need to, lose them more.
Mhm.
So, Salud was closed to new patients for a while. They recently reopened last quarter. It's great for the community, and I think they're going to be very very cautious about just watching those panel sizes and making sure that providers feel supported because they're a valuable resource and we can't get new patients in if we lose our PCPs. So we just I think to me that's like one of the biggest challenges.
Awesome. Thank you. A couple minutes left. Any other closing questions for Mai?
If nobody else has
Hi, Grant.
one.
Yeah.
So given your Salud's patient population, I wonder if your hours of operation are a challenge for your patients. Do you run on the weekends or in the evenings at all?
Yes. So I believe the last appointment is at 7:10. We close at 7:30 p.m. Monday through Friday. Maybe a little bit earlier on Fridays, maybe close at 6 on Fridays. I'm not sure. Um, I see Leah's on, so Leah, feel free to like correct me if I'm wrong. We are open on Saturdays, all day Saturdays, and we are open Sunday mornings, half day. So we do have some evening hours, and weekend hours. Um, a friend of mine is at Ventura County, and they were running like a care gap closure clinic at like 6:30 in the morning to help, accommodate their also ag worker population. And I was
Interesting.
like, oh my gosh, how did you get physicians to come in at 6:30 in the morning? So I think it was like just one physician who like volunteered for that. But so I don't know if that's really a sustainable solution per se, but it's an interesting idea about, not only evening access, but early morning access. But we do see this. I did quite a bit of access work when I was at Salud, and patients are very clearly wanting more afternoon, evening visit slots. And I think that again, I think what's challenging is that PCPs also want that work-life balance, and I have two small kids. Like I want to be here for dinner with them, and it's hard to be at clinic at like 7:30 p.m. So how do we kind of address all that?
Thank you.
Awesome. That was fantastic. Thank you. All right, we're going to go to specialty now. And we wanted to bring in Dan. Oh, so Trina, actually, Trina, I know Trina very well, so she probably has a quick question. Go ahead, Trina. CNO Wattsville Hospital. If you're on mute, Trina, otherwise we can come back to you. Yeah, I'll come back to her after, unless you, yeah, Trina, I'll come back to you after Dan, and that's okay. Great. Dan, you want to jump in, introduce yourself, and talk about
Yeah,
where you
yeah.
stand?
My name is Daniel Greene. I don't have slides tonight, so I apologize. I'm a urologist up at Primary Dominican Hospital and some of the surgery centers. I'm with Dignity Health Medical Group or Common Spirit Medical Group. And so I wanted to talk, a little bit from a specialty standpoint. I've been in the community since 2018. I finished my training in Cleveland Clinic and came essentially directly out here and started practicing. And from a specialty access standpoint, I have some statistics that I pulled from our database for the Dominican market, so Common Spirit. And, I have some primary care statistics as well. If you look at the third next available, and I often like the third next available because it's not the first, you can get a weird time slot, but the third next available for average people for a new patient primary care was 57 days
Wow.
in the Common Spirit market. And for specialty, it was 23 days. And from a specialist, it's a unique balance because when you talk about patient panel, from a primary care standpoint, you tend to get the patient panel, and that's your volume. Where from a surgical standpoint, I need to keep access open all the time. I have to see new kidney stones, I have to see new cancers, I have to see new urinary retentions to generate the OR volume to fill the space. And so from a system standpoint, they actually want me to have as much access and as much new people as possible. I do think urology is unique in the sense that we often see a lot of non-operative stuff, refractory erectile dysfunction, BPH managed with meds, kidney stone prevention, these types of things. And so my interaction with access in the market is both personal and as well as primary care access changes, it affects me directly. And so first I'd like to talk about, my access. And so right now the landscape has shifted quite a bit, at least in the Santa Cruz market. I don't know the surrounding counties quite as well, but Andrew Noor at Watsonville is retired. Peter Breton's panel is closed. Sutter is really limiting their access to Medicare or CCAH. So right now, the only practicing urologist in Santa Cruz that sees new Medicare, as far as I can tell, is myself. And so it's been problematic. There's two of us, and my colleague took a big leave and is still currently on leave. And so every referral that comes to my office, a provider triages. And so we don't have an access nurse. We're physically looking at your referral and trying to figure it out. And so we see doctors on duty, Salud, Watsonville, Dominican ER, all of our PCPs, quite a few people. And so when you come, and we really try to take it seriously, kind of like how May was saying, if you come with a real renal mass and you get referred to me, you're going to get moved to the front of the line. Where if you're an adult male with refractory erectile dysfunction, unfortunately, you're at the back of the line. And then from there, the perception I have perceived is my schedule is full essentially every day. And so those add-ons are what I call the gray space. And so it's, I never schedule Friday afternoon. I end up working a lot of them. I often will take a day I have booked off and give it back, is what I say, to add patients, add surgeries. And so generally we can get people in sort of a tolerable amount of time. I think a reasonably safe amount of time. But in the crunch times, if anyone takes a leave, if there's any change, it becomes increasingly hard. So the end of 2025 is just terrible, terrible, terrible. And so multiple referrals that came through either got declined because I just didn't have space, or if they were too urgent, just got sent back to the referring provider and said, look, you got to send them elsewhere. I can't see this 14 centimeter renal mass and operate on them in any timely fashion. And so personally, it's been really, really tough. May talked about burnout as the leading thing. I often will go to the administration and say, look, I need to work less hours. I need to work less physical hours. You need to hire more people. But then it's met with the realities of the finances for the community, the logistics, recruitment, office space, all of the limitations that we struggle with. And so my experience with access has been, it's getting worse. The patient panels seem to get bigger and bigger. It's imperative that we keep access, but we're really Tetrising a very, very complex schedule. And so then if you're the person with the erectile dysfunction that's waited 3 months for your appointment, and then it comes up to your appointment and we cancel you because I have to schedule a new day of surgery, I don't know where to put you because I don't have another day to schedule you into a gray space. Do I schedule you at the end in 3 more months, or do I, it's very, very, very tough. And so from a specialty access standpoint, a lot of times we drive the hospital's bottom line. And so my plea with the hospital and the administration is, look, you gotta create more access. This is driving your finances. And I'm optimistic that over time we'll create access, but we're really having to triage people. And it may come. I remember when I first came out here, I interviewed in a group very, very far north of here in Reading. And they said, look, if you're not cancer or a stone, we're not seeing you. You just don't get to get seen as a urologist patient. And so it may come to something along those lines where the people that want to see urologists may not, unless they have a real problem. And I'm hopeful that that through recruitment and these types of things that we can maintain access. But that's been our experience, at least personally, and in the urology clinic. The other thing that I've encountered a little bit is I interface so much with medicine, and I'm always thankful for my medicine colleagues every day. You know, people will say, "Oh, what about my heart?" I say, "Look, if it's below your diaphragm, I'm not really sure. Like, I need my medical colleagues to help me risk stratify you, make sure you're set for surgery or capable for surgery." One of the recent examples I give, I had a delightful older lady that went to the ER with some nondescript flank pain, and she was found of a 20 millimeter stone. Obviously needed surgery. We have to treat her. She comes into my clinic. Her blood pressure is 210 systolic. She's got no family doctor. That's the first time she's seen anyone. And she's sitting in my clinic, 210 systolic, dyspnea on exertion, and a 20 millimeter ureteral stone. The ER said, "You're not acute. You can go home, go see Greene." And so I say, "You got to see a family doctor." Our common spirit PCPs can't see anyone quickly. So this is early in the year. She gets routed to Planned Parenthood before they closed. She sees Planned Parenthood. They start a medicine. They close. I see her for surgery. She comes in. Her blood pressure still 210 systolic. Canceled surgery. She gets routed to another county health clinic. They start another medicine. Don't have time to follow up. She comes into surgery. Now her potassium is completely abnormal. And so we cancel surgery a third time or a second time. And then I had to pre-admit her to a hospital just to make sure her potassium and blood pressure were optimized prior to treating a kidney stone as an outpatient surgery. And so these kind of experiences, it's, from my productivity and from my throughput, like, I just want to say, you've got a stone, and practice my expertise to treat her stone. To optimize her blood pressure it needed to be done to make surgery safe, but finding that follow-up, because she doesn't just need one appointment, she needs two, maybe three. And it was really, really tough. And so I often am the first point for folks into the healthcare system. Kidney stones, renal masses, blood in the urine, urinary symptoms. They come into the ER, they come into the urgent cares. They don't have family doctors, and they can get routed in me. And the specialty third next available is much quicker than our third next available for PCP. So they'll see me, and then I'm trying to coordinate getting them in. And we don't have a very robust system. They'll come back and say, "Look, everyone's full. Sorry." And so the access problem has both affected me directly in clinic, but also indirectly through the patients and their experience and getting the care they need. And so we often juggle back and forth. I think the administration was a little bit more willing when I was sending lots and lots of referrals out, just over to Stanford or to Sutter. And when insurance has to pay different prices, they're not always the most happy for that. And so what are we doing? What's our plan? I'm trying to recruit more humans. And I think that's the key. I mean, I really think fundamentally, I'm in a very managed health system. And so interacting with administrators that want a business case for everything, I'm telling them, like, look, the business case is, I'm not working anymore. You figure it out. And so I think often the provider is willing to Tetris and juggle and make it work for the safety of patient, because we've taken the Hippocratic Oath. We're interested in it. But it's hard. You balance your personal burnout with providing for the patients, and you're no good if you're not working. And so I do think from a health system standpoint, we really have to say, like, this is what I'm willing to do. This is my limits. And above that, I'm sorry. It's, someone else has got to figure it out. I remember I compared to someone the giving tree, and I said the giving tree is the hero in the story. And so I think it's the moral that we've all been tasked with, but I'm not confident that it's a long-term sustainable solution. I think we really need to have more people, more access, more RNs. May hit on, the quality of the RN, how much it's helped. In our office, we have 2 RNs actually. And without them, we're dead in the water because there's so many catheter calls, UTIs. Any person that has a lot of UTIs gets sent to us, and they keep having a lot of UTIs because there's really not a cure. And so they just keep calling over and over and over. And so to have the nurse say, look, it sounds like you got a UTI, I'll order a urine culture. And then I'll get a message. It's, Miss X has got a UTI, proposed antibiotics, boom. And so it can be, I think it can be streamlined. I think we have to task everyone in the system to operate at their full scope of license. We just need more people. We need more access. That's my opinion. So thank you.
That was awesome, Dan. I love the story. It just gave me chills. I'm so sorry to hear that, but this is why it's important to be able to have a voice and share it. Could you explain to me just a little bit more about what when you said grace-based? Tell me again how that works in your example.
Yeah, so I have Friday afternoons, for instance, for my gray space. I never book it, and then I try not to book it until that week.
Oh,
And so it kind of gets built on. And so I really don't open the schedule. Like the front desk has no access to it. It's closed. But I send a lot of messages that are, add Mr. Smith on at 2 o'clock Friday, 3 o'clock Friday, and then I can find that space that is sort of my personal space that I allocate to what I perceive is needed in the time.
great. That makes a lot of sense. That's very helpful. So again, sharing tips and tricks, what works for you as a urologist, and supporting most of Santa Cruz County. Thank you. Questions for Deanna? I see some. Actually, Mike, do you want to say a few comments that you put in the chat?
Oh, sure. I was just, yeah, I feel like we can manage BPH. And they get it to
Yes,
see
I agree.
PCPs to manage BPH. That's sure. We can talk about that. But I think, yeah, so I guess my second comment, just in terms of returning patients back to PCP, like, I think this is more, I've seen this happen more for like cardiology or, plus minus renal if they're not needing dialysis. But like, I think there's more work that we can do as a medical society to say, hey, here's my recommendations and return them back to PCP, because I think we have to trust our training that we can do it. And primary care can design systems where, you know, um, when some of our colleagues might not have the same either level or intensity or training as a physician necessarily, there are ways to work in teams with mid-levels to help manage specialty conditions where they're not like really needing specialists care. I just feel like I see a lot of that where like I could be doing that, but and then I'm like, oh, well, I'm really glad I'm not because I've got like a million other things to talk about with the patient. But I guess that was kind of one point.
That's
And
great.
then just talking about, again, on a systems level, e-consults. I've experienced both on the clinic level using e-consults. So you're trying to avoid like basically when you're like, I don't know, should I send this person to like a specialist? Is it really like, or can I just get an answer like much more quickly? Because I have this really focused question and how do I like create this focused consult question? So sort of training some of our providers around that. And then now on the plan side, supporting that e-consult resource. Um, but it's work. It's work that the PCP does, right? It takes time to like put the consult case together, pull all the relevant labs, pull the relevant imaging, pull the relevant EKG. Like, is that really something that the MD or the PCP needs to be doing? How do we work with our, whole primary care team so that we say, hey, I want this consult question to answer this thing, and you guys pull all the, here's the relevant data, go pull it so that you guys, somebody else is putting together that question so we can get the answer quickly. And then maybe that saves the patient a trip to, see the specialist that wasn't really necessary and we could save for somebody else.
I mean,
That's great.
I think certainly everyone at the top of their license. I didn't even mention our APP. We have a physician associate in our office that's amazing. I mean, so a lot of the referrals that are obviously, less operative or less in depth, you may never see a physician in our office. You may only see an APP. And so I think as everyone really at the top of their license is critical to addressing access.
Great. I see Leah, then Casey. So we'll go with Leah first for questions. Thanks. We have about 6 minutes left for questions.
Yeah, thank you. I'm just sort of making the observation that it sounds like, and I agree with this, that the global problem is lack of humans, lack of trained humans. And, there's lots of efforts to train more humans. I'm working with the residency. Grant is working with, on the medical school level. But I have the observation that um, our medical societies and our people and we have sort of been the source of this problem by restricting and limiting things, limiting the number of trainees, limiting the number or limiting or having attitudes that limit access to employment for APPs and that sort of thing. And so I'm wondering or I guess I'd like some commentary on whether or not we maybe need to redirect our efforts toward those levers of control that are currently restricting the humans.
Mm. That's a very, very interesting question. I think we have some experts that could speak to that. I'm not going to put anyone on the spot, but does anyone want to jump right in on that?
I mean, great question. My opinion probably differs a little bit than some of the formal medical societies. When I say everyone at top of scope, I really believe that. And, I mean, I think like everyone should see the absolute best provider in the world, but that's not reality. So everyone needs to get seen, but it's a balance. And I do think everyone should be at the top of their scope. And, I agree with I think primary care physicians can manage a lot of stuff. I see a variable level of confidence with that management. I see a variable level of patient interest in it. A lot of referrals are patient had nocturia wants to talk to urologist. And it's like, ugh, like how much wine do you drink before bed? And they're like 3 glasses. I was like, well, I think I found your problem. So it's, everyone has to, I think, dive in, but everyone's so busy, right? It's like it's much easier to just kind of live the system. Change is hard. But I agree with you. I think the levers in place that allow everyone top of scope should be exercised. I think, when we talk about like more humans, my perception on Santa Cruz is it's a uniquely amazing place. And so I do think in our counties, Monterey, San Benito, Santa Cruz, we could recruit probably better than we give ourselves credit for. I mean, I think the cost of living is certainly a detriment, but I think there is a bigger opportunity to recruit into the region and then also keep kids, with Grant and the UCSC and keep kids that want to stay here back in the region. Because it is fantastic. I'm not from here originally, but it's pretty nice.
Awesome. That's really, Casey, you'll finish us out with your question for Dan.
Yeah, thanks. I wanted to double down on the e-consult question. I wondered if you are, only because I was part of the team driving it in our clinics, and wondered from you, Dan, and other specialists on the call if you've seen any measurable improvement in access, and if we as a community might want to really go all in. Briefly, when I was in LA County, when e-consult rolled out, I don't know, 16 years ago, the e-consult system was integrated into the county specialty network itself, so that the e-consultants were the specialists who would ultimately see the patient if needed. So it created this really nice, continuum of care. And oftentimes they could have said, when they did, here are the guidelines on how a PCP could retain care in the medical home. So if we're seeing glimmers of success here and there, maybe we go all in and we create a more robust structure, where you are part of the e-consulting system, advising the local PCPs on how to better take care of patients in the medical home.
Can I
I
just
think that'd be
interject?
very yeah, no,
Yeah,
sorry, go
yeah,
sorry, May. I think it'd be very, very reasonable. I mean, I think something to do it, the system would have to create time for me to do it.
Right.
yes.
Because, time to give is the problem. And so
Well,
there would have to be something.
and that's the same problem for the PCPs, right? I mean,
Yeah.
this whole thing is, no continuity, no time. The bigger systems, in our model where we are private practice, we have to unlearn patients from that 7-minute visit where they're suddenly put off to a specialist, and the expectation is that we're supposed to refer to specialty care. We can't take care of this. And unfortunately, the whole big system continues to reinforce that. There was a really fascinating, I don't know if some of you have access to the FMX meeting in Anaheim, but there was a fascinating AI meeting there about what's going to happen to primary care as this sort of starts to develop. And Renee Churchow, who is this wonderful leader in primary care, and she runs a clinic that's affiliated with Harvard, made some comments about much of this work because of AI, because of technology that brings us back things like retinal scans to the R clinic, to not the ophthalmology clinic, is going to start moving some of this work back into primary care. But the problem is we don't have the time. We don't have the people. We have too many patients. This is going to come undone as we move forward because of the lack of resources, the lack of focusing. Primary care is the center of care where people should have first access, where things like the structure for BPH should be in our clinic, not at urology, not in the 7-minute visit where we send people up the tree. That's where our problem is.
Janine, could you introduce yourself just for those that might not know you? And you're just
Sure. I am Janine Rodems. I'm a family physician in the community. I've been involved in state and national work, and we're about to go to our 10th year of being in a direct primary care practice. So we've stepped off of the insurance wheel completely in order to improve time, continuity. We actually still do our hospital work, so we maintain that continuity with people going in-house and coming out. So we know where our patients are and what's going on with them. And I stepped off of the insurance wheel for these reasons. I did not want to do concierge. What we are doing is not concierge care because that's usually a higher price point with a narrow socioeconomic group. And we want lower prices, access to care. And our model across the country is slowly showing better care, improved access. We are now starting some of the employer networks because they recognize that we are a 20 to 30% reduction in cost. And we love the time, the commitment, the continuity. We get to see our own patients that the model offers. And we're sort of on the edge of this new movement to try to get us more focused on primary care first. They should be able to come in 1 to 2 days, for whatever urgent thing is going on. And you should know those people when they come in. And that's what the commitment is of the direct primary care movement.
awesome. I haven't formally asked you, but we've talked about it. I think you'd perfect for a panelist on part 2, like in 2 months. We'll have to make sure a date works for you. I think having you and a couple of colleagues figuring out who you think would be a good partners for that panel would be a really nice segue to the energy from this call. So great. Thank you very much, Janine. Very, very much appreciated. Any other comments for Deanne? And then we're going to move on to Casey. Great. We kind of thought this kind of sandwich of primary care, specialty primary care is exactly the right kind of attention. And then we'll have a second part 2. So, and then Casey, to introduce yourself, and thank you for your time.
For sure. Thanks, Clay. I'm happy to be the other slice of bread in the sandwich. Wow. First of all, I want to just kind of harken back to Mai's comments about the time spent. I want to appreciate everyone for being on this call. This is like prime post-work, family time, dinner time. So, wow, supreme gratitude for you spending this moment spent with us and for the opportunity to speak about what we're doing. I never thought I'd be in the healthcare workforce business, but I find myself there. And so as we're talking about access to care, that's where I'm going to focus a lot of my time, is how we build up our healthcare workforce here and elsewhere. Um, yeah, so a little bit about me, Casey Kirkhart, DO, family doctor. Um, I've been really leading, organizing, supporting clinicians, physicians especially, for my entire medical career for about 25 years. I was leading medical students back in New York and part of AMSA, American Medical Student Association. Um, trained at Harvard UCLA, where I did my family medicine. I was a chief there for a fourth year. And then I was in LA at an FQHC for 6 years, where I was an associate director. And I launched our transition from paper charts to EHR Epic. That was wild back in the high tech days. And then about 10 and a half years ago, moved up here to Santa Cruz, where I was the chief medical officer at Santa Cruz Community Health, which encompasses the Women's Health Center, what was the East Cliff Family Health Center, now is the Live Oak Health Center, and up in Ben Lomond, the Mountain Health Center. While I was there, we tripled everything, tripled our workforce, tripled our budget, tripled our services. And I was a part of the original team that applied for and launched our we can't say now, brand new family medicine residency program out of Dominican, in partnership with Morehouse School of Medicine out of Atlanta and Common Spirit, who's put forward a ambitious goal to launch dozens and dozens of family medicine residency programs across the country. And ours is the inaugural program, just recognizing the amount of commitment in our community to public health, community health, developing our workforce with a mission orientation to address inequities in our healthcare system. So now we're 2 years strong. We recruited 2 amazing classes of residents, and we just finished interviewing actually for the third year. So I was big part of that program. And for the last couple months, I've been chief medical officer of a medical group called Wellness Equity Alliance, which is a private medical group that does street medicine. We're based in LA, San Bernardino, Coachella Valley, the high desert. We have operations in New Mexico and Albuquerque, and soon to be in Denver, where we're leaning heavily on case management to bring medical care, mental health services, substance use treatment to people living where they are, in the streets, in shelters, wherever they may be. So really trying to fill all the gaps of where our healthcare system has really failed a large part of our community. So I've interviewed, hundreds and hundreds of physicians and medical providers. I've hired and supervised dozens through their launching or sustaining their career. I've had, fortunately, many fewer I've had to let go and help them find other more appropriate employment, or help them find their next step. And I've had a few gems where people have said to me, "You've helped me create the perfect job," where by addressing our community needs, our talents, our skills, I've been able to create amazing opportunities for physicians. So I've seen kind of from one end of the other, the whole spectrum of clinician experience. And having witnessed our journey through burnout and through struggles, and I've kind of landed on this philosophy that I want to share briefly, but I'm going to get down into how it translates into actual brass tacks, things that we can actually do that supports this philosophical approach. And to me, I'm a perennial optimist. What I did is I basically took burnout and said, like, where is this burnout coming from? And to me, I call it the absence of joy. So when you have joy in not just your work, but in your personal life, in every aspect of your life, that's what sustains you. And joy is more than feeling happy. It's more than feeling content. Sometimes you have a really hard time and you can feel joyful because you've achieved something near impossible. I've had, many exhausting days after clinic, or back in residency days after working, 24-hour shift in the ER. I'm sure many of you have had this, where you're totally physically drained, mentally drained, exhausted, but you feel so fulfilled, you feel so alive because of what you were able to accomplish. You're ready to go back there, get up in the morning and do it again. That's what I associate to joy. That's how I define joy, and how we can see that manifest in medicine. And so I've kind of settled on what I call the 3 C's of joy. And so I think you'll find if you have most of these C's happening for you, you will be joyful. And you might, if you've had, if you felt burnout, if you felt that things weren't working out for you, especially professionally, you might realize that it was one of these C's that was absent. So I want to go into a little bit about them and then highlight some specifics. So the first C of joy is community. And I think we do a pretty good job as physicians in creating a community for ourselves. We identify with being physicians. We understand each other's struggles. We have the same mission to help people. So I think we do a pretty decent job. I mean, look at the attendant who's here tonight. I think we do a pretty great job of supporting each other and finding joy in community. The second C is competence. So we want to be excellent at what we do. Like Dan said, we want to work at the top of our license. We want to continue to accumulate knowledge, skills, and we want to be great clinicians. We want to help in ways that now that we could never have imagined, years before. So we want to be really competent. We want to be excellent at what we do. The third C of joy, and the one I want to spend more time, is choice. Well, we want to be able to choose how we spend our time. You could say it kind of leads into autonomy. Like how do we define how we spend our time? We want to do the job that we set out to do. And when we are asked to do things that are outside of that, we feel joyless. But when we can do the things that we set out to do, we find joy in that. So, for example, one of my greatest successes when I was CMO at Santa Cruz Community Health was carving out administrative time for all of our clinicians. So we said we were able to continue maintain visit access, productivity, finances, everything the same by reshaping our schedules. We said to every clinician, you're a 1.0 FTE, 80% of your time is seeing patients, and 20% of your time is protected admin time. We value that time. We value calling patients on the phone, following up with labs. We value refilling medications. We value clinical conversations with your colleagues. So we will protect 20% of your time to do that. And we were able to achieve that without any impact on bottom line or anything like that. And that was probably the number one achievement where we were able to say, we value this work. You want to do it. You see value in it too. We will protect that for you. I think about in my new role, how case management and utilizing community health workers has really been critical to helping patients navigate this highly, highly complex system and connecting them back to their PCP. So we have street teams who go out into the levees, into the encampments, into RVs in the desert. And if their teams are largely led by community health workers, a lot of them have lived experience, and they are able to maintain continuity while the clinician like me does like a monthly video call. So it lets all of us work to the top of our level. And I can do primary care from afar with something led by case managers. So
That's amazing.
one part of choice, right? Like we're choosing this path. We're doing what we're able to do, the top of our scope. We're not kind of getting stuck in this. Like Dan, your story was really impactful to me. Like you need a case manager, you need a navigator, you need a social worker, you need everybody to address all of those obstacles so that you can then, work at the top of your scope and know that patients are being taken care of, they're being supported through this process. Another part of choice is being able to do the things that really resonated with you in the past. And when we built this residency program, we knew the opportunities were there for recruitment, right? That we're going to have 8 family physicians, well-trained, trained in our community, knowledgeable about our spaces, entering into the workforce in Santa Cruz County, right? So we definitely want to keep them. But really the silver lining, the gold from that was how much this impacted our current physicians, where now you can pivot from being a full-time family physician or specialist in your clinic to being an educator, right? Tapping back into those, because that's part of our culture. We want to teach, we want to learn from each other, we want to upskill, we want to engage in the future of medicine. So realizing that even more than the residency being a recruitment tool, it's a retention tool. So now we're able to keep family physicians working more hours, longer for longer period by having them precept residents in the clinic, and some of them even coming on board as faculty. So that's been a huge retention tool for us. And then the third point around choice is around who makes decisions, right? We all want to be a part of the decision-making process. And looking at how our institutions are structured and ensuring that there are physicians at the top levels of leadership in all parts of our organizations. Even better, that we have a stake in that, we have equity in that, we have partial ownership in those institutions, and that really varies. Like those of us who have been in community medicine, we're not a part of that. We're employed directly by our clinics. We don't have equity in our organizations. Some of the organizations that you all are a part of do, but now I am a part of a medical group where I do have. I'm part of the executive leadership. I do have ownership of the company, and I'm doing practicing medicine deep in the community, right, where there's no access to care. So we deem it humanitarian entrepreneurship, right? There's really no structure right now in healthcare. There's no national efforts around anything constructive. Like public funding is gone. Public institutions are eroding from the top level. So it's a real opportunity for those of us who want to be entrepreneurs, who want to bring together public efforts, public dollars, private money together to really make it creative inroads into the healthcare system. This is probably the best time to do that. So just some examples of how we can lead with seeking joy. And it's not just like, oh, you'll wake up one day and feel good, you'll feel happy. No, we can actually create these opportunities for each other and for the people we work with through creating community, elevating our skills and becoming more competent, and by giving us more choice, more autonomy, and agency in the systems that we work in.
That's great. That is not at all where I thought you were going to go tonight, but that was really, really
cool.
And super appreciative,
yeah.
and I really appreciate that refocusing. That's amazing. So questions for Casey. We have about 10 more minutes. We were allotted till 7, but we don't have to go that long. But I'd love to have this continued conversation. That was a nice, fresh direction there, Casey. Thank you.
Sure.
I'm tempted not to jump into street medicine because I had such a nice call and chat with Reb about what she's doing in Monterey not too long ago. So we'll talk about that next time. Okay, Donna, go for it.
Casey, I'm curious. When you were mentioning the communities that you're working in, can we all assume that you're also working in Santa Cruz and Monterey, San Benito counties? With patients that have no access, doing street medicine?
Street medicine, not yet. That's something that we're looking to expand. Yeah, that's part of the what's amazing about having a company that's not attached to a location is that you can really insert yourself in different counties and different communities, and so that's on our 1 year, maybe 2 year trajectory is to establish some services up here.
Because I think there's a lot of doctors that work in the ER that would say it's needed. It's needed in this region.
Yeah. Oh, sure. Yeah, we're working closely with Eisenhower Medical Center down in Palm Springs. We actually just created a referral system with them so that their ER docs can refer homeless patients, folks who are been to the ER 4+ times per year, who are just out of incarceration, people with mental health and substance use challenges. They have a hotline to our team, and our case managers go directly and support them coming out of the ER. So something that really syncs up well with emergency department work.
That's great. Yeah,
Thank
that
you.
does really, it's relevant to access. So, yeah, I'd love to talk to you more about having a talk set up in May again with Reb Close and what they're doing with street medicine in Monterey and her
Yep.
team. So, excellent. Well, other questions? Otherwise, I can ask a few more. I'm sure we got some folks on here that have stuff to say.
So I
I have a
assume you're,
question.
Oh,
go
sorry.
ahead.
Go ahead and then Grant.
Yeah. Hi, Casey. This is Devin Francis.
Hey, Devin. Hi. Good to see you.
Yeah, from Salute. I was curious your take, and maybe anybody else on the call's take. I know I came on late. But yeah, when you're kind of talking about creating joy and preventing burnout and just, what did you find were the biggest challenges to doing that? Or what were the strategies that you used that you felt that helped you kind of overcome some of those challenges when you're working in a more traditional kind of clinic setting?
Yeah. Really, the number one take home is that there's no one solution for every person, right? It's really creating that personal understanding, like what excites you, where's your path taking you, and helping to create that for them. I know, and that's probably the hardest thing. Like we want like this one like across the board solution, but it takes some time to get to know people and know like what they're passionate about. And sometimes the realization is, wow, I'm so excited for you. You're passionate about this, and we don't have ways to give you that here. So sometimes you have to like find it elsewhere, which is a wonderful thing. So kind of like letting go of that. But at the same time, I'm really like knowing where people like what people find joyful and helping to create that for them. But it's really individual.
And Casey, that's what this call is for me, having 25 people come together, on the evening and being able to share. And
That's
this
right.
is exactly why I'm with this group and have these people on the call, which are, I see places I don't know and I want to get to know. So I've got a couple of questions here. I think Christina first, sorry, Grant, and then Christina. Grant, if you can go ahead.
sure, just, it sounds to me like your pair mix is probably 100% Medi-Cal. And if
with the street medicine work, you
Yeah.
mean? That's
Yeah.
right. Yeah,
and
that's right.
so I'm surprised you can be joyful with that, I guess. How do you make
Well, I think it's a mess, but we're fortunate in California where, CalAIM has really leveraged Medi-Cal dollars around, mental health, behavioral health. And so we're really leaning heavily into, so we have local government contracts, but also with the health plans down in Southern California that really see, as does the Alliance here, really sees the value in providing case management and behavioral health services and following the dollars that support that.
Thanks. Great. Christina,
Yeah.
thanks, Grant. Christina, then Dan.
Yeah, thank you. Can you guys hear me okay? I'm in the hospital, so it might be a little bit bad
Yeah.
connection.
Sure can.
Good, awesome. So I'm Christina Gamboa. I'm an OBGYN physician in Watsonville and work at Salud para la Gente, and also am faculty with the residency in case there's people who I haven't met yet in the community. Thank you so much, Casey, for the talk. One quick question I had, well, it's probably a longer answer, but if you could just highlight a little bit about some of the like value added you've seen with the community health workers that you partner with, and leveraging their lived experience as it relates to specifically getting people connected. So maybe some examples of like ways that it's worked really seamlessly and ways that maybe it's been challenging. Because my feeling here as a provider in this community for over a decade is that we don't use community health workers enough to connect people. And so if there's just like one or two pearls of things that you've learned so far, I would just love to hear about it, or definitely talk more offline.
Yeah, it's an amazing question because it's really opened up my eyes to how we can provide continuity of care in the most challenging of spaces. It really is about developing trust. If you can, would you trust, if I just showed up at your RV, would you trust me to start asking you about like the most intimate medical questions? Probably not. But if you knew the person who was there on a weekly or biweekly basis, who's from the community, who's established that rapport with you, and they bring me the physician to you, the trust has already been established. So I think really leaning into that and leveraging it, and not taking advantage of it by any means, but just realizing that the trust development starts first. That's you had to lead with that.
That's great. Thank you for the question, Christina. Dan, you're next.
Quick question. So, talking with people who've done private practice and these things, the old adage was, you got to see 20 patients to pay for your light and overhead. And then you start to pay yourself with like the 21st, the 22nd kind of thing. And so I find that as we talk about more and more humans, we as the providers have to have like more and more billable, more and more stuff. And so certainly there's the financial realities, and Janine may be the smartest person in the room to just avoid all this. Like my administration recently, within the last month, announced some project acronym name where they want to improve access for the community with the goal of getting every provider above the 50th percentile in terms of productivity. And so like my perception from the administration is like, look, you want all these things, you have to be very, very busy. You have to generate a lot of encounters. You have to have a lot of billable stuff. And so when you talk about like, at the county, you gave everyone 20% protected time, like that's great. I would love to see something like that. And maybe you can comment, is that widespread? Is that, like my perception is most health systems are not protecting their providers. They're working them as hard as they possibly can.
Thanks, Dan. Casey?
No, I think you're right. And what was starting to happen when I was leaving Santa Cruz Community Health was, while we really need to use that admin time to have productivity, right? That became, it started to be, started encroaching in that space because of the financial situation that health centers are in right now. I don't think it's common. But the way that we did it was by, me putting my CFO hat on and saying, like, look, we can shift schedules and maintain productivity through this change and retain people, right? Otherwise, people will leave and we'll have this, the same issues that we've talked about where there's no access because people have left because they haven't been given the chance to do what they want to do, and you're not valuing that important clinical time. So I think part of it, is the challenge to all of us is like, to the extent we can, like leaning into that CFO, put our CFO hat on. And I mean, that's what sold my clinic on the residency, right? Like at least the financially minded people, right? Because of it, like, why would we hire on younger, experienced doctors? They're going to take up more time. They're going to take up more space. No, actually, when you have one preceptor, I might see, say, for the sake of argument, I could see 10 patients in a half day, but I'm working with 2 third-year residents who each themselves see 8 or 10 patients per half day. You effectively almost doubled my productivity by having residents. So the first couple of weeks, years are tricky, right? Because the interns are they're half as productive. But eventually you start seeing where a residency program could be more productive. Granted, they take up more space. You have to have more support staff, but from a purely productivity perspective, you can be, more productive with residents. It gets challenging when we have a mixture of different levels of training from medical students to, sub-Is to first year, third year, right? We have to adjust for that as we introduce more learners into the space. But from a high, a third year resident in the clinic, it's a magnifier of productivity.
That's great. Thanks, Casey. And I'm chuckling at the chat. Thanks, Brian, for the comment. You're welcome to jump in if you'd like.
I'm missing the chat too, yeah.
That's interesting. Any comments, Christy or Brian, or just go with the chat? That's funny. Jeff Gordon?
Yeah, thanks so much. I've been really hanging back and enjoying this conversation. Nobody on the screen knows me. I've been in Santa Cruz about 4 years. I practiced as an antique in San Diego for 40 years. as a solo private family practice doctor. And regarding some of the other things that have been mentioned, during the Omicron surge, I managed COVID outbreaks in the homeless in Los Angeles for the LAPD, LA Department of Public Health. And I was training community health workers in New Orleans in 1969. I've also been president of a visiting nurse association, and I spent 8 years on the California Medical Board licensing and disciplining doctors. I just want to reflect on the quality and the caliber and the passion and the values of all the conversations I've been hearing today. Really a great community and a great spirit. I probably should stop there, but in answer to the question of professional societies limiting providers, recently the California legislature allowed a law which would allow independent practice by nurse practitioners. And because of the medical society, they loaded that with so many years of training and mentorship that it's really an onerous requirement. And those attitudes by the California Medical Association still exist. Another thing that I would like to share with you is one of my specialists here in Santa Cruz, who I should probably not name, her practice was acquired by a venture capital fund headquartered in Switzerland that has a 41% return on investment per year. And if you think dignity is pressuring you, Dan, as a specialist, wait till you work for venture capitalists. And, we've all heard stories about ER docs working overtime and understaffed. And when they raise their hand to complain, they get laid off. So that is an unfortunate circumstance to see venture capitalists buying specialty practices in Santa Cruz. I would suggest that this attitude, Dan Hernandez carried the torch to the CMA, and this attitude needs to be carried from our community to them and give them the power to create real healthcare in California. It's really been a privilege to listen to this conversation.
Thank you, Dr. Gordon. To that point, one of the other topics over the year will be advocacy. So I see Dr. Kirkhart on here. Thank you for joining, Kara. Don Hernandez will be a speaker in the future. And that's exactly what we need is to keep these conversations going and keep the energy going and learning from each other. Thank you for your comments. Okay, we're about to wrap up. So we're at 6:49. Any other comments or questions, or I can close this out. Let me see if I got any hands up here. So just to wrap up, the community C of your 3 C's, Casey, and then Mai's comments about mentorship and community just makes me want to just call out from where I sit in the hospital. Trina's on the call, Crystal Grady, Jessica Santiano is on. These are people that keep me focused and going every day amidst all the uncertainty and the day-to-day at the hospital. And I want to just recognize that is exactly why we're here tonight. And every other month, I think we'll continue this. And I hope everyone's found this enjoyable tonight and worth your time. And with that, I want to wish you a lovely evening and go play with the kids and have dinner. Maya, thank you, Maya and Dan and Casey. You've been amazing.